Okay, so if you're a medical trainee, you've seen it 1,000 times, right? A lab report comes back, and boom, it's flagging anemia. But what do you actually do next? Well, think of this as your practical guide for how to approach erythrocyte disorders, starting with that very first clue.
And this right here, this is the single most important rule. You've got to think of yourself as a clinical detective. See, anemia isn't the end of the story, not even close. It's just the first piece of evidence that tells you a case has been opened. Our job is to follow the clues and find the real culprit.
Every investigation has a starting point. And for us, that's the initial lab report that puts the focus squarely on one thing: the red blood cell.
So at its core, what is anemia? Well, it simply means your body doesn't have enough red blood cells to get oxygen where it needs to go. And that can lead to symptoms like feeling tired all the time or getting short of breath. Now, how bad those symptoms are really depends on just how low the count is and, importantly, how fast it dropped.
Our very first piece of evidence is going to come from the complete blood count, or the CBC. This is the tool that first flags the anemia, usually with the hemoglobin and hematocrit levels. But just as important, it gives us our first set of clues, the erythrocyte indices. And this is where the real detective work kicks in. The first, and I mean the most important step in cracking this case, is to look at the mean corpuscular volume, or MCV. This one number tells us the average size of the patient's red blood cells.
Think of the MCV as a major fork in the road. It immediately splits our investigation into three completely different paths. Are the cells too small, what we call microcytic? Are they normal-sized, or normalcytic? Or are they way too big, macrocytic? Each of these paths leads to a totally different group of suspects.
Okay, so we've sorted the cells by size. The next big question is, what is the factory, the bone marrow, doing about all this? And the answer to that lies in the reticulocyte count. And this is just a brilliant piece of the puzzle because it's so logical. See, reticulocytes are just baby red blood cells, fresh off the line. So a low count tells you the bone marrow factory has a production problem. But a high count, well, that tells you the factory is kicking into overdrive, pumping out new cells like crazy because the old ones are getting lost or destroyed somewhere out in the body. All right, let's follow that first pathway, the low reticulocyte count. This is the case of the faulty factory. We're going to investigate some of the most common causes of underproduction anemia.
Now, here's a classic challenge you're going to face all the time. You have small cells, a microcytic anemia, and a low reticulocyte count. Two major suspects should immediately pop into your head: iron deficiency and thalassemia. And telling them apart is absolutely key. So how in the world do you tell them apart? We look for patterns. Now, both have a low MCV, and yeah, the iron studies are different, obviously. But the real game changer here, the clue you have to look for, is the RDW, the red cell distribution width. In iron deficiency, the RDW is high because the marrow is sputtering, making cells of all different sizes. But in thalassemia, it's a genetic defect, so all the small cells it makes are uniformly small, which means the RDW is normal. That's a huge clue. And you can see it perfectly right here on this slide. Look at the left. In iron deficiency, it's just chaos. This wild variation in size and shape is called anisopopycocytosis. But now look at the right, in thalassemia. It's so orderly. The cells are small, yeah, and you see some target cells, but they're all remarkably uniform. The visual evidence is just undeniable. All right, let's switch gears for a second. What if the cells are too large, macrocytic, and the marrow isn't responding? Well, that path points us straight toward megaloblastic anemia. This is usually caused by a deficiency in vitamin B12 or folate, which are both essential for making DNA. And here it is, the smoking gun, a hyper-segmented neutrophil. You see, because B12 and folate are needed for all rapidly dividing cells, the problem isn't just with the red cells. When you see one of these multi-lobed neutrophils, it's a giant flashing sign that there's a systemic issue with DNA synthesis. The key takeaway, this isn't just an erythrocyte problem. Okay, now let's go all the way back to that fork in the road and take the other path, the one with a high reticulocyte count. Remember, this means the factory is working just fine. The problem is that red cells are being destroyed out in the circulation. We call this hemolysis, and boy, does it leave a dramatic trail of evidence.
For this part of the investigation, the peripheral blood smear basically becomes our crime scene. The shape of the busted-up red blood cells can tell us exactly how they're being destroyed. So, let's take a look at some of the key culprits.
First up, spherocytes. These are these little dense red cells that have lost that pale spot in the middle.
This happens when macrophages in the spleen literally take bites out of the cell membrane, causing it to round up into a sphere. This points you toward either an immune attack or a problem with the cell membrane itself. Next, we have bite cells. And again, you can thank the splenic macrophages for these. In conditions like G6PD deficiency, oxidative stress messes up the hemoglobin. The macrophages spot this damage and remove it, literally taking a bite out of the cell. It's a very, very specific clue.
And finally, and listen up because this one is a true medical emergency, schistocytes. These aren't just bitten cells. They are sheared, fragmented red cells that have been physically torn apart as they move through the circulation. Seeing these is a massive red flag for something called a microangiopathic hemolytic anemia, or MAHA.
So after following all the evidence, we're ready to put it all together and finally solve the case. It really is all about using a logical step-by-step framework.
So let's just recap that diagnostic pathway one more time. It all starts with the CBC. From there, you categorize by cell size using the MCV. Then you check what the marrow's doing with the reticulocyte count. Next, you hunt for those morphological clues on the peripheral smear. And finally, you use all that evidence to order specific targeted tests to confirm your prime suspect.
And this brings us right back around to our fundamental principle from the very beginning. We don't stop at the word anemia. By digging deeper and identifying the precise underlying cause, whether it's something as common as iron deficiency, a vitamin deficiency, or a really dangerous hemolytic process, we unlock the door to focused, effective treatment for our patient.
So the investigation is complete. The diagnosis is confirmed. Your detective work has a direct impact on what happens next. The question is no longer, what's the cause? It's, what's the cure? What's your first move?